So good morning, and I will try to give you an overview on the actual rules of high-flow nasal cannula versus standard oxygen therapy and versus NIV. First of all, high-flow nasal cannula is an oxygen therapy, but compared to the traditional oxygen therapy administered through the Venturi mask, high-flow nasal cannula allow to administer really high flow to our patients, up to 60 liters per minute. And we have the chance to heat the flow, so we have high temperature and high level of humidity, and the temperature is rounding around 37 Celsius degrees. So high-flow nasal cannula became, in particular during the pandemic, one of the first line of treatments in patients affected by acute respiratory failure. But I would like to focus a little bit on some physiological effects that make this O2 therapy completely different from the traditional oxygen therapy administered with the Venturi mask. But these physiological effects are again different also from the physiological effect that we can reach with non-invasive ventilation. With high-flow nasal cannula and with the high flow compared to the traditional Venturi mask, as you can see, here is the high flow, here is the traditional Venturi mask, we can reach high level of FiO2 during the whole inspiratory phase of our patients because of the high flow. While during the Venturi mask, the high level of FiO2 can be reached just at the beginning, and then the air that is breathing the patient is mixed with the room air, so we are losing the effect of the high FiO2. Second of all, because the humidity and because the high temperature that is supposed to be around 37 Celsius degrees, we can reduce the deficit that normally we create with the standard oxygen therapy in terms of cell dysfunction, and this can help our patients. And then, because we have high flow, we can create a sort of washout in the upper airways, and the gas flow decreases the upper airways dead space and allow to create this washout. And then fourth, compared to a traditional oxygen therapy through a Venturi mask, with the larger cannula we can reach a sort of PEEP, a sort of distending pressure. As you can see, with the larger cannula we can reach 4 centimeters of water of distending pressure. That it's not the same pressure that we can obtain with a CPAP, where we can start from 4, 5, but we can also get more and higher pressure, but it's something that can be really useful in our patients with hypoxemic respiratory failure. And then the last but not the least is the comfort that we have when we are using high-flow nasal cannula compared to the traditional Venturi mask, and also compared to non-invasive ventilation in our patients, because our patients are definitely more comfortable with the cannula, and the risk of displacement is definitely lower compared to the Venturi, and sometimes also compared with the face mask during non-invasive ventilation. But you know, there was a lot of discussion in the past decades about high-flow nasal cannula and non-invasive ventilation, and I would like to report two big review and two big consensus conferences where the authors try to analyze all the papers in the literature, trying to understand how high-flow nasal cannula was used and in what kind of group of patients. And in this review by Jean-Damien Ricard, they explain that because the benefit and the physiological effect of high flow nasal cannula, we may assure higher FiO2 to our patients. The high flow and the distending pressure may increase the airway pressure, and thus we can increase the end expiratory lung volume. We can reach a little bit of recruitment and increase lung compliance, and these help us in reducing the patient respiratory drive, respiratory rate. And on the other side, because of the humidity and the high temperature, we increase the comfort of the patient. But as you know, we have many kind of different acute respiratory failure. So as we always did for non-invasive ventilation, we have to select our patients depending of the pathology. So under the umbrella of the acute hypoxemic respiratory failure, where definitely high flow nasal cannula improve oxygenation, improve end expiratory lung volume, and may reduce the work of breathing, we have to remember that we have the cardiogenic pulmonary edema, and then we have the ARDS, two different pathologies in which the results and the effect of high flow nasal cannula may be completely different. And we well know that when we applied high flow nasal cannula to a very severe patients with acute respiratory failure due to an ARDS, it's really important to strictly monitor the patient in an ICU. And the major problem is not to delay the intubation. Never delay the intubation in the most severe patient. Then we have the hypercapnic patient, another story. So high flow nasal cannula was used also in hypercapnic patients because of the physiological effect. The results were not so bad, but there are not many studies, in particular randomized control studies in the literature, telling us that high flow nasal cannula may be definitely superior to non-invasive ventilation as first line of treatment. And then high flow nasal cannula can be used in the post extubation to prevent reintubation in high-risk patients. And even here, we have to distinguish between the low-risk patients and the high-risk patients. And definitely, high flow nasal cannula was used in high-risk patients, but in this kind of group of patients, high flow nasal cannula did not seem to be superior to NIV. Always depend from the patient, always depend on what we want to take care. For example, abdominal surgical patients that may have atelectasis the 48-72 hours after surgery, probably high flow nasal cannula may help, but not a lot as CPAP, because the high pressure that we can give with CPAP help us in opening the atelectasis. So even here, we have to select our patient population to be treated with high flow or with NIV. No evidence actually for the usefulness of high flow nasal cannula during the pre-oxygenation phase. And in a big conference reports, the role of high flow nasal cannula as strategy in adult patients, they try to give us some guidelines, and they produce some strong and conditional recommendation. So definitely there's a strong recommendation for the use of high flow nasal cannula in hypoxemic respiratory failure, and also the study that this group of experts analyzed didn't underline the risk for delaying intubation. Then there are conditional recommendations in the use of high flow nasal cannula in the post-extubation and in the post-operative high-risk patients, and they particularly analyze obese patients after cardiac or thoracic surgery. No recommendation at all for the peri-intubation period. However, I grew up with NIV. with NIV. And I use NIV with face mask, with the helmet. So I was really skeptic at the beginning with high flow nasal cannula. But I think also because the people were trying to take high flow nasal cannula as alternative to NIV. High flow nasal cannula cannot be considered an alternative to NIV. Are two different strategies that can be considered as synergic in our patients, and that can help us in treating at the best our patient. So this is the, I think, the best way to use both without saying, no, I cannot use NIV because I have high flow nasal cannula. And this is one of the demonstration. This is one of the first randomized control study on COVID-19 patients from Domenico Grieco and our group in Rome from our institution. And they analyzed the effects of high flow nasal cannula versus helmet non-invasive ventilation, in particular analyzing the day free from respiratory support in patients with COVID-19. And their results show that there was no difference between high flow nasal cannula and helmet NIV in terms of days free from respiratory support. They used to ventilate, actually used to treat moderate to severe ARDS COVID patients. But when they went to look at the cumulative incidence of intubation at 28 days, they found that in the group that was treated with the helmet non-invasive ventilation, the risk and the incidence of intubation was significantly lower than the group that was treated with high flow nasal cannula. And this result was probably related to the fact that they treated moderate and probably a little bit more severe patients where probably a stronger treatment can be needed. And so they concluded that no difference in terms of respiratory free days from respiratory support, but the use of non-invasive ventilation was associated with a less incidence of intubation. And how we use normally in our ICU high flow nasal cannula. When you use high flow nasal cannula, exactly when you use non-invasive ventilation, you have to monitor your patient. And the most simple mode of monitoring your patients is the peripheral oxygenation. And you have to find a value that is your borderline, and you can see that if the patient is able to maintain the saturation above 90 or 92%, it can keep standard oxygen therapy. And in any other case, after the traditional oxygen therapy, you can switch to high flow nasal cannula. If high flow nasal cannula is not enough in reducing work of breathing and in improving oxygenation, then you can switch to NIV. And again, if NIV is not enough for that patient, you have to be ready to prompt intubate that patient, in particular if we are speaking about acute hypoxemic respiratory failure. And this was well underlined also in this expert consensus statement where high flow nasal cannula was considered one of the first line of treatment for COVID patients, in particular when COVID patients were not able to maintain a peripheral oxygenation above 90 with a traditional oxygen therapy. But they also look at the use of NIV, and NIV was considered first line in patients with a mixed acute respiratory failure, but also every time that the patient was not able to reduce the effort and to respond properly to the high flow nasal cannula. How about our experience? In our clinical practice, we look always at that kind of at the patient that we have. And even here, we distinguish between hypoxemic patients, post-operative patients, and we treat also less severe COVID-19 with high-flow nasal cannula, especially outside from the ICU and the emergency department. And when we start high-flow nasal cannula, as well and as we start non-invasive ventilation, we have to choose the optimal interface. It's definitely simpler for high-flow nasal cannula, but even the choice of the cannula can be tricky, because the cannula should leave a visible gap between the prong and the nostrils, and the head strap never cannot be tight too much on the head of the patient, and we have to be careful up on the ear, because high-flow nasal cannula is a treatment that is supposed to last not for 1 hour, not for a couple of hours, but even for days continuously. So we have to avoid everything that can increase discomfort in our patients. And then every time check the positioning of the tubing, because the risk of displacement is less than with the Venturi mask, but we also have to fix the tube to avoid the risk of malpositioning. And then I would like to say that especially in the ICU or in the emergency department, you know that high-flow nasal cannula can be delivered with different machines, but when you have the possibility to have just one machine that simply can help you in switching from invasive to non-invasive to O2 therapy, back and forth, it's really simple, because at that point your focus is not in changing the interface and changing the machine. You already have the same machine, and it's definitely faster, change just the interface, and this can definitely relieve a little bit also the work of our nurses, because you have everything at the bedside. The other thing that I think that it's important to note, exactly as with non-invasive ventilation, you have to explain to the patient what you are doing, and my advice is never start with very high flow, because it creates immediately discomfort in the patient. So normally it's really rare to start with 60 liters per minute since the beginning. You have to start exactly as you start with NIV, with a low level of pressure and PEEP, and then you increase step by step. Here we don't have the monitoring of tidal volume, but you have the monitor of the respiratory rate of the patient, of the peripheral oxygenation. So you can start at 30 liters per minute, and then step by step you can increase, trying to see if the patient dyspnea and tachypnea can be relieved with that level of flow. So definitely high-flow nasal cannula, it's useful in treating acute respiratory failure of different origins, and it's useful also in preventing reintubation in the post-extubation period in high-risk patients. However, it's always important to see, as well as NIV, as well as we did with NIV, that we have to select carefully the patient population. We have to strictly monitor the most severe patients if we want to start high-flow nasal cannula. And always we don't have to consider high-flow nasal cannula as an alternative to non-invasive ventilation. Two different treatments for different level of severity in our patients. Thank you.